Before I start my topic, I'll let you know that I was given PTC subtypes, but I'll be covering a little bit pathological update also in thyroid cancer, because without this knowledge, PTC subtypes may not be helpful for you alone. So quickly, without wasting time, I'll just start. So this is the outline of my presentation. I'll be starting with evolution of the classification, followed by introduction, then going on to low risk follicular thyroid cancers, then follicular variants of PTC, PTC variants or subtypes, high-grade thyroid carcinomas, Hurtl cell, and some biomarkers of tumor progression or adverse biology. So as you can see in this picture, it depicts the timeline of the changes in the histological classification of well-differentiated thyroid cancers, which started around in the late 1950s, where it was classified, PTC was classified by architecture alone, that is papillary and or follicular. Only in 1960s, Lindsay classified and recognized the nuclear features of PTC in follicular lesions. And only by late 1977 was the first follicular variant of PTC defined. But by the time it was 2000 and late 2000s, we see a lot of development in and changes in the histomorphology and the naming of these cancers, especially follicular variant of PTCs, which were found to be associated with RAS mutations. And also there was an entity of well-differentiated thyroid cancer with undetermined malignant potentials. Later, towards 2016, Nikiforov et al. Identified and defined a new entity for us that was Niftp, which caused a revolution in the pathology of thyroid cancers, and where most cancers were being diagnosed as malignant, Niftp was still regarded as a benign tumor. So going on to the new WHO classification, it's based on the cytogenesis, that is the cell of origin, histology, molecular features, and biological behavior is one of the important components that is added in this classification. So this is the old classification, that is fourth one, which came out in 2017, which innocently defined tumors based as papillary, follicular, Hurtl cell, poorly differentiated, anaplastic, and so on. And what we see in the new classification on your right is the classification is based on the cell type, that is cell origin, that is follicular cell, also based on the behavior, that is benign tumors, low risk neoplasms, and malignant neoplasms. They have added few things and few things have been removed. As I go through this lecture, you'll realize what all has been removed and what all has been added. So WHO fourth had follicular adenoma as a separate entity. However, in the fifth WHO classification, follicular adenoma became clustered into benign tumors. And I won't be talking much about benign, so I'll quickly move on to the next hyalinizing tubercular tumors, which was a separate identity in WHO fourth classification. However, it came under low risk neoplasms along with Niftp and thyroid tumors of uncertain malignant potential in the fifth classification. Also in fourth classification, there was encapsulated follicular patterned thyroid tumors, that was follicular tumor of uncertain malignant potential and well-differentiated tumors of uncertain malignant potential, which came into the low risk neoplasms in the new classification, along with hyalinizing tubercular tumors and Niftp. The non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which was initially classified as other encapsulated tumors, are now regarded as low-risk neoplasms because of their nuclear aggressive features. Also, follicular pattern of PTC and encapsulated variant of PTC were reclassified into malignant neoplasms as invasive encapsulated follicular variant papillary carcinoma. There was an entity called as papillary microcarcinoma. We all know that PTCs measuring less than or equal to 1 centimeter have been called microcarcinomas. But my PTC microcarcinoma should not be considered as a distinct subtype, is what has happened in the fifth WHO classification. Also, cribriform modular variant, that was a well-known entity associated with the FAP, and we have read it extensively, answered it in exams, and written it in our exams. Now, in WHO fifth classification, it comes under thyroid tumors of uncertain histogenesis along with sclerosing mucoepidermoid carcinoma with eosinophilia. So it's no more a variant of PTC. There's follicular thyroid carcinoma of no special type has come into under malignant neoplasms as follicular thyroid carcinoma. Poorly differentiated carcinoma has come into follicular derived carcinomas high grade, along with anaplastic follicular cell derived thyroid carcinoma and differentiated high grade thyroid carcinomas. Anaplastic, as already discussed, anaplastic follicular cell derived thyroid carcinomas. The entities which was a separate entity as squamous cell carcinoma is now considered a subtype of anaplastic follicular thyroid follicular cell derived thyroid carcinoma in the fifth WHO classification. MTC, not much change. We all know it is thyroid C cell derived carcinoma. It's only that it is put under the C cell derivative tumors. Mucoepidermoid carcinoma of the thyroid have been reclassified as salivary gland type carcinomas with mucoepidermoid carcinoma of thyroid and secretory carcinoma of the salivary gland type. Mucinous carcinoma has come within the spectrum of mucoepidermoid carcinoma of the thyroid and secretory carcinoma of salivary gland type. Entity which was sclerosing mucoepidermoid carcinoma with eosinophilia is reclassified along with cribriform modular thyroid carcinoma as sclerosing mucoepidermoid carcinoma. The Hürthle cell tumors are no more described as Hürthle cells further. They have been renamed and reclassified into oncocytic adenoma and oncocytic carcinoma of thyroid and come under follicular cell derived neoplasms. Already mentioned about oncocytic carcinoma of thyroid comes under follicular cell derived neoplasms. So this is a new entity in WHO fifth classification, thyroblastoma, which comes under embryonal thyroid neoplasms and unusual embryonal tumor associated with DICER1 mutations. So oncocytic adenoma of the thyroid, the term Hürthle cell is now discouraged, reason being that these cells were originally described by Hürthle and are actually, it was meant to be for C cells of the thyroid. Oncocytic change in thyroid follicular epithelial cells is what these Hürthle cells were named as, but now they have to be named as oncocytic cells because of their intense granular cytoplasm. Follicular adenoma, that is benign lesions, can also have oncocytic change. And more than 75% of oncocytic cytology is used for a classification of oncocytic adenoma or oncocytic carcinoma. Moving on to low risk follicular thyroid neoplasms, they are morphologically and clinical features are indeterminate between the intermediate between benign and malignant tumors. They can develop metastasis, but incidence of it is low. Hence, a close follow-up is required once a diagnosis of any of the given below is made, like NIFTP, thyroid tumors of uncertain malignant potential, and hyalinizing trabecular tumors. So, starting with NIFTP, this is an old criteria which had come forth in 1994 with the encapsulation of clear demarcation, follicular growth pattern with all of the following. It is less than 1% papillae, no samoma bodies, less than 30% of any other variant. The latest classification actually says no papillae should be present. So when comparing the original criteria with the revised criteria brought by Nikiforov et al., the true papillae that was initially allowed are not allowed now. Other than that, lack of BRAF, B600E, Red PTC arrangement and third promoter mutations are optional, and that is what adds to its indeterminate prognosis. So the new classification also says that tumors less than 1 centimeter in size or oncocytic tumors fulfilling the histologic criteria of NIFTP, that is no papillae and nuclear features of PTC with well circumscribed margins, no vascular or capsular invasion, should be classified under NIFTP rather than PTC. So all this while these tumors were being classified as micro PTCs. As you can see in this picture, there is a well defined circumscribed lesion, this one with no papillae, and these are follicles with some nuclear features of PTC. Some nuclear clearing and grooving can be seen. So going on to the next low-risk follicular cell-derived neoplasm, that is thyroid tumors of uncertain malignant potential. These are well-differentiated thyroid tumors with follicular architecture that may or may not be capsulated but are well circumscribed, but invasion remains questionable after thorough sampling and exhaustive examination. So according to this, there are two subtypes according to their nuclear features. So if nuclear features are absent, that is, there is low nuclear scoring, it is named as follicular tumor of uncertain malignant potential. Whereas if nuclear features are pronounced, that is 2 to 3, they are reclassified as well-differentiated tumors of uncertain malignant potential. So if you can see in this table, there is the one that is highlighted here. There is follicular tumors of uncertain malignant potential, when differentiated tumor of uncertain malignant potential, and Niftp. If you see here, the nuclear features in well differentiated tumor and NFP is more than follicular tumors of uncertain malignant potential. Hyalinizing trabecular tumors, these are less than 1% of all tumors. They are solid and well differentiated and delineated from surrounding thyroid tissue. They have trabecular architecture and elongated or polygonal cells. The cytoplasm is abundant and with eosinophilic granular cytoplasm. MIB1 immunostain shows diagnostic membranous staining. This is a very important point, and for your exam also if this tumor comes, because MIB1 is actually a nuclear stain. Only in hyalinizing trabecular tumor do these cytoplasmic membranes take up MIB1 immunostain, and that is actually the diagnostic clinging feature in hyalinizing trabecular tumor. They also lack BRAF and RAS mutations. So this is a hyalinizing trabecular tumor, and this particular brown staining of the cytoplasmic cell wall is the MIB1 immunostain. So what if we discuss about Niftp and hyalinizing tumors and uncertain malignant potential tumors? So according to what I have told you till now, NIFTP and HTT may have aggressive nuclear features. So a thyroid lobectomy followed by clinical and radiological surveillance should suffice in them. However, when you get a diagnosis of uncertain malignant potential, a close follow-up is required. So going on to follicular variant of PTC, it is an old friend who has become a new guest now in our malignant neoplasms of the fifth WHO classification. We already knew that there was follicular variant of PTC and encapsulated variant of PTC. Now what they have done is this follicular variant of PTC has been separated out of the other subtypes or variants of PTC because it is found that RAS-like mutations when present will have expansile growth and subtle nuclear features. That is, they would be encapsulated forms. However, when BRAF-like mutations are present, the tumors are more infiltrative and have florid nuclear atypia. Hence, FBPTC have been reclassified as infiltrative types and encapsulated forms of PTC. So here, this is an infiltrative type of PTC with the clusters of cells. On ultrasound, you can see the diffuse infiltrative margin that's not as clear as seen in an adenoma or an NIFTP, and nuclear features, nuclear grooving, and cytoplasmic clearing is present. So what distinguishes encapsulated FBPTC from follicular thyroid carcinoma? Can anyone answer this question, please?
Capsular invasion, more than 4 foci will indicate a widely invasive FTC.
No, follicular. No, I'm talking about encapsulated FBPTC.
Encapsulated FBPTC won't be having any capsular invasion, whereas FTC would be having capsular invasion.
They can have encapsulated FBPTC can have.
Okay.
अगर encapsulated FBPTC का नहीं होगा तो we will have a diagnosis of Niftp.
Niftp, yeah.
Yeah, so encapsulated FBPTC from follicular thyroid cancer. What will distinguish it? It's a nuclear morphology that is going to distinguish.
Yeah.
So what are the histological subtypes of follicular thyroid cancer and follicular variant like papillary thyroid cancer? So there is oncocytic, that is more than 75% oncocytic cells with no high-grade features and clear cell change. There may be minimal invasion, that is tumor or capsular invasion only. There may be angio-invasive FTC or FBPTC. There can be widely invasive, that is gross invasion through the gland. So what about the management? So minimally invasive tumors, you can do a local resection, that is only a lobectomy. But when it comes, like you have done a hemithyroidectomy and there is minimal invasion of capsular or vascular, a local, only that treatment is enough. You can follow up the patient. But when it is widely invasive, you require completion thyroidectomy and adjuvant therapy in the form of iodine to prevent loco-regional recurrence and or distant metastasis. So going on to papillary thyroid cancers, variants or subtypes, which is actually today's topic. So the characteristic of nuclear cytology and papillary growth or invasion is actually the diagnostic criteria of PTC. Can be diagnosed on FNAC, but the best nuclear and other morphological features are seen on histopathological specimens. So according to the latest classification, these are the carcinoma subtypes. That is classic PTC, tall cell, columnar, hobnail, diffuse sclerosing, solid, oncocytic, Wathen-like, clear cell, spindle cell, and PTC with fibromatosis, fasciitis-like or desmoid type stroma. So what has been excluded from this classification is microcarcinoma, follicular variant, and cribriform modular variant. So the ones in blue are the subtypes which have normal or a benign indolent type of course. Whereas the one in red, that is the tall cell, columnar cell, hobnail cell, diffuse sclerosing, and solid trabecular have more aggressive features. We'll see why they would have aggressive features and what aggressive features do they account for. So already discussed, variant has been replaced by subtype. PTC microcarcinoma should not be considered as a distinct subtype. It should be considered equivalent to a PTC. And tall cell subtype, tumor cell height that was previously 2 to 3 times, it was a lax criteria, has now been strictly said to be 3 times the width. Though still they do not have any microscopic scale to measure it, and it is based on what they see on the microscope. It is still very subjective. So starting with why this subtype has been changed, why this variant has been changed to subtype is mainly to allow for consistency with other WHO classifications and to avoid any confusion, because when the pathologist does a molecular diagnostic classification, that is where they use genetic variants. It's more related to molecular subtype. So when we talk about morphological subtypes, it is supposed to be renamed as subtype. When you talk about molecular level things, that's when you name it as variant. All right. So classic PTC has an architecture consisting of papillae with monolayer sheets and in 3D groups. The main features are nuclear features. The most important ones are enlarged crowded nuclei with overlapping, oval irregular shaped nuclei, longitudinal nuclear grooves. They'll have intranuclear pseudo-inclusions, pale nuclei with powdery chromatin, thick nuclear membranes. They may have macro and micro follicular architecture within. Other features which come into classic PTC would be Samoma bodies, multinuclear giant cells, and presence of variable colloid like stringy, ropey, or bubblegum kind of colloid. Also, you may see few hobnail cells, few oncocytic cells, few squamide metaplasia, but that doesn't add to its high risk or aggressive histology. It will still be called as classic PTC. It is the most common type and has a good prognosis. So coming on to the next one, which is an aggressive histology, it is the tall cell PTC subtype. It consists of mainly polygonal elongated cells, polygonal or elongated cells with a centrally placed nuclei and an eccentrically placed nucleoli within the nucleus. These cells are typically called as tail-like or tadpole cells. They have a lot of mitotic figures and intranuclear cytoplasmic inclusions which are present. They account for around 4 to 16% of all PTCs which are diagnosed. They are clinically present in elderly men more than women, and with large tumors, with extrathyroidal extension, vascular invasion, with increased risk of recurrence, with presence of central neck nodes at the time of diagnosis and distant metastasis at the time of diagnosis. Also, 90% of these tall cell subtypes are BRAF V600E mutated or TERT promoter mutations are present, and when they are present, it is associated with worst outcomes. But what importantly has to be remembered is at least 30% of the morphology should be tall cell. To call it a tall cell subtype, 30% of the morphology should be of tall cell. Even if there are less than around 10% of the cells which are tall within a histology, it may not be accounted as a tall cell subtype, but pathologists might tell you that PTC with tall cell area. So that should alert you, because even that amount of tall cells are going to be associated with adverse clinical course in patients. So moving on to the columnar cells, these are rare and account for 0.4% of PTCs. On your left, these two images are of FNA slide, that is liquid preparation, and this is a histopath formalin stored specimen. They consist of columnar cells with the hyperchromatic nuclei, oval and pseudostratified nuclei, which reminisces of any secretory epithelium like respiratory epithelium. They have supranuclear or subnucleolar cytoplasmic vacuoles which are present. They may be present with, they may have this papillary, trabecular or follicular pattern cells. And however, the nuclear features of classic PTC are less prominent in columnar subtype. They are at presentation, they are usually present in older males, just like tall cell variant. They are large and mostly are invasive. But these columnar subtypes can also be present in young patients. And when present in young patients, they are well circumscribed tumors. They are usually female patients, and hence presence of just few columnar cells in any histological PTC specimen does not predict worse outcomes, unlike tall cell variant. So this has to be differentiated and should not be confused between tall cell and columnar subtype. So presence of columnar subtype does not predict worst outcomes. So moving on to a rare variant, which is a Hobnail variant, which is present in less than 1% of all PTCs. Can someone tell me what a Hobnail is?
It is an eccentrically placed nuclei in the cell, which bulges out of a cell
A
membrane.
hobnail. How does it look? A hobnail. So it's a nail. Huh.
Uh,
It's like a big nail with a hob on the head end side, a huge bulge, and a screw at the lower bottom, a lower surface. So it's like a screw. Okay. So you can probably appreciate in this. Okay. So there is a bulging nucleus. So this is what a hobnail actually looks like. So it is the large atypical bulging of the cell. The bulging is towards the apical surface, and the cells lose the polarity, and they are very very discohesive, and hence this adds to its aggressiveness. They have micropapillary structures and other complex papillary patterns. But this type of morphology should be present in more than or equal to 30% of the slide. So when I say 30% of the slide, the pathologist will report either on 2 mm square area, or when they say in high power field, it's called 10 high power field. So 2 mm square area of the tumor or 10 high power field is equivalent. So this hobnail variety was first described only in 2010 by Asioli et al. And these tumors have been found to be very, very associated with rapid disease progression. Patients die within 5 years. So usually when we talk about PTC, what is the survival that we explain to our patient? Can someone tell me, what do we tell our patients? Do we say 5 year survival in PTC, or is there some other year that we say?
20 years survival.
Yeah, we say 20 years survival in PTC. So this is the type of PTC which is very, very aggressive, and patients die within 5 years. They are, and the also hobnail, pure variety of hobnail does not exist. It's very, very rare. It usually coexists with other kind of aggressive histologies like a columnar subtype or a tall cell subtype or diffuse sclerosing or a solid variant. It will always coexist. 70 to 80% of tumors are BRAF V600E, TERT, and PIK3CA mutated, and usually present in younger patients, unlike other variants which are present in elderly patients. So the next variety is, next subtype is diffuse sclerosing subtypes. It constitutes around 3% of all PTCs, and present mostly in children and young adults. The characteristics are its bilateral lobar involvement, extensive lymphovascular invasion. They'll have multiple samoma bodies. Here also you can see all these samoma bodies are present. This is an FNA, and this is a histopathic slide with multiple vacuoles. They're called a cytoplasmic, holes inside the tumor. And they have squamous metaplasia. There'll be marked lymphocytic infiltration and prominent fibrosis. When on ultrasound, radiologist picks up a snowstorm appearance, that is what should alert a diffuse sclerosing subtype. They are actually the samoma bodies and multiple classifications that are present. So around it is when in children, it has aggressive, though present in children and young adults. It's mostly related to radiation exposure, and was seen around 10% of the children who were exposed after to radioactive iodine in Chernobyl incident. They may be associated with BRAF mutations in 20% of the times. The next variety is solid subtype. The reason of keeping these two in the same slide is both these variants are both these subtypes are common in children. Solid subtype is more commonly present in children than diffuse sclerosing type. and both are related to radiation exposure. And solid subtype is more commonly associated with radiation exposure. Up to 30% of children post Chernobyl accident had solid trabecular pattern. So on histologic on histology, they have trabecular and nested areas with the papillae or follicles of colloid, and this characteristic feature should be present in more than 50% of the area. And nuclei should show typical features of PTC. They may also be present in 1 to 3% of adult PTCs and have poor prognosis. When present in adults, it has poor prognosis. When present in children, it still has a better prognosis than in adults. It is not BRAF V600E associated, but TERT, RET, and NTRK1 mutations are more commonly seen. Because of its intense trabecular and solid component which is present, it may mimic MTC, and pathologists may have to do a calcitonin and CA on this to confirm their diagnosis. It may mimic amyloid. Okay, so going on to the less rare ones with with prognosis which may not be as aggressive as the other subtype. Wharton subtype is actually a unique, has a unique histomorphology of just like parotid Wharton's tumor. They have papillary architecture with lymphoid follicles, and their characteristic feature is that they are associated with lymphocytic background and Hashimoto thyroiditis in 90% of the time. They will have abundant oncocytic cells, that is pale, eosinophilic, granular cytoplasm with nuclear features of PTC. They are rare types. They are present in 0.2 to 1.9% of PTCs. Oncocytic subtype already discussed. They have nuclear features of oncocytic cells with abundant granular cytoplasm and papillary and solid cytoplasm with the lymphocytic infiltrate. So PTC with fibromatosis fasciitis like desmoid type of stroma is very, very rare type of tumors. They may confuse with squamous type or anaplastic thyroid cancers, but there are no mitotic figures, and nuclear features of PTCs are present with dense desmoid type stroma. So what are the subtypes and features of high-grade thyroid carcinoma? So they are follicular derived carcinomas which are high-grade, that is differentiated high-grade thyroid carcinoma and poorly differentiated, and anaplastic follicular cell derived thyroid carcinomas. So in follicular derived carcinomas which are high-grade, the prognosis is intermediate between well-differentiated and undifferentiated carcinomas. They are rare. 1 to 6.7% of all thyroid carcinomas come under this category. And this one, which is highlighted with red, the differentiation pattern is good. That is, there are papillae which are present in differentiated high-grade tumors, but their mitotic activity and tumor necrosis is present. So that makes them intermediate in category. So they are not like PDTCs, but they are also not like well-differentiated tumors. So when we're going into PTTC, we all have to know about this Turin's criteria and how it is different from differentiated high-grade thyroid cancers. So in PTTC, there should not be any feature of PTC. However, some differentiation is still present in differentiated high-grade tumor thyroid cancers. That's what differentiates from PTTC. Rest other mitotic figures, tumor necrosis, convoluted nuclei are as present as in PTTC. So this is a PTTC which shows intense insular patterns with nuclear staining and a lot of mitotic figures. So in differentiated high-grade tumors, the IHC would be still positive for, because differentiation is present, it would be positive for TTF1, PAX8. Thyroglobulin may also be present because of presence of some differentiation. MIB1 is relatively high, 10 to 30%. Aggressive medullary thyroid carcinoma type features may be present, that is calcitonin, chromogranin, and monoclonal CEA can be done to distinguish them from follicular cell derived poorly differentiated tumors. So they are not PDTC, they are not well differentiated, they are not anaplastic. It's a new entity which is between somewhere between poorly differentiated and well differentiated. So what is the new understanding of anaplastic thyroid carcinoma, and why is squamous cell carcinoma included in this section? That's because testing of all anaplastic carcinomas should be done for the presence of BRAF V600E mutation via IHC or genotyping. Anaplastic thyroid cancers are bizarre. They have a lot of stroma, a lot of spindle cells, and a lot of mitotic activity. So squamous cell carcinoma is now classified as a morphologic pattern of anaplastic thyroid cancers because BRAF V600 mutation is present in 87 to 90% of the cases. The outcome is similar to anaplastic thyroid carcinomas. They express PAX8 and TTF1 in 91 to and 38% of the cases respectively, confirming their follicular cell origin. And they harbor a differentiated thyroid carcinoma in 3/4 of cases, almost of all papillary thyroid carcinoma. So it still comes under high-grade thyroid cancers. So oncocytic thyroid carcinoma, so Hurthle cell is no more. Oncocytic carcinoma of the thyroid is referred to invasive malignant follicular cell neoplasms composed of at least 75% of oncocytic cells in which nuclear features of PTC and high-grade features are absent. This term replaces Hurthle cell carcinoma, and no other major substantive changes is present to the description. It still remains poorly iodine avid in post-thyroidectomy follow-up, and still the prognosis is same as was described previously in Hurthle cell. So except the name, nothing else changes under Hurthle cell carcinoma. Already described the features. So coming on to the last one, biomarkers. Most of the PTCs and infiltrative and follicular thyroid carcinomas have BRAF type or RAS-like mutations. Only when they move on to addition of TERT promoter and AKT, PTEN, do they move from differentiated high-grade tumors and poorly differentiated to ATC. Though there is also a concept that ATC may arise de novo, but it may become undifferentiated from a well-differentiated tumor. So left side is a normal thyroid follicular cell where TERT promoter is present, promoter gene is present, and it causes the normal thyroid follicular cellular senescence and cell cycle arrest. But when this TERT promoter is mutated, it causes this bizarre cloning of telomerase repeats and makes the cell immortal and causes limitless replicative potential, and that causes high aggressive histology tumors, as already discussed before in the subtypes. So PTC patients with synchronous BRAF and TERT promoter mutations will have worse clinical outcome, is what is the take-home message. So in summary, papillary microcarcinoma, cribriform morular, and follicular encapsulated variant are not a subtype of PTC anymore. Tall cell criteria is strictly come back to 3 times the height of the cell. The term Hurthle cell is discouraged, and squamous cell carcinoma of the thyroid is now considered a subtype of anaplastic carcinoma. Thank you.